Hello, my name is Kira O'Brien. I'm an assistant professor of neurology and a dementia specialist at the University of Pennsylvania. And today I'd like to share with you a project called WATCH, or the Warning Assessment Tool for Cognitive Health. This project is being done in collaboration with Dr. Kevin Johnson, who is a professor of pediatrics, informatics, computer and information science, bioengineering, and science communications, and Dr. Eric Eaton, a research associate professor of computer and information science at UPenn. The problem we're trying to solve with this project is low detection of Alzheimer's disease and related dementias, the most common causes of progressive cognitive and functional decline in older adults. To receive appropriate treatment of these conditions, they must be detected early, but about 50% of individuals with dementia are undiagnosed. And this problem disproportionately affects Black and Hispanic individuals and those with less education. These patient populations are also at higher risk of having dementia. There are new disease-modifying therapies for Alzheimer's disease, and the introduction of those into the clinical space has really amplified this problem because patients get more benefit from these treatments if they are earlier in the disease course. So it's even more imperative that they are diagnosed early. Beyond affording access to medication, early detection also enables patients and their care partners to access psychosocial supports that improve quality of life and reduce caregiver burden. Most patients first present to their primary care provider for cognitive concerns, but evidence shows that it's difficult to detect cognitive impairment and dementia in primary care. The earliest stage of cognitive impairment, or mild cognitive impairment, is only detected in about 8% of cases in primary care. And we know that there are a lot of barriers to detecting and diagnosing dementia in the primary care setting, including lack of time, competing priorities, lack of familiarity or comfort with the diagnostic evaluation, and lack of clinical decision making and care supports for the clinicians. So, this project seeks to support primary care providers in detecting cognitive impairment through a system that uses electronic health record data, computer vision, and language processing to detect signs of cognitive impairment due to possible Alzheimer's and related dementias. When implemented in clinics, this would provide real-time alerts to notify primary care providers that the patient has motor or speech findings that are often seen in patients with cognitive impairment, and then it would recommend a formal assessment for that patient to evaluate for cognitive impairment. So the goal of this project is to develop and validate a predictive model to achieve this detection. So the first aim, we are generating a labeled data set in patients with high and low risk of having cognitive impairment based on an existing predictive model called eRADAR, or the EHR Risk of Alzheimer's and Dementia Assessment Rule. And then the second aim, we'll use this data set to generate and validate a new predictive model that's better able to detect features related to Alzheimer's and related dementias. So taking a closer look at our approach, we will run the eRADAR predictive model for a cohort of older adult primary care patients at Penn Medicine. eRADAR uses electronic health record data to predict risk of undetected cognitive impairment. And so we will take those risk scores and identify patients with low and high risk of undetected cognitive impairment. And from that, recruit a population of 200 individuals, a third in that high risk group and two-thirds in the low risk group. And we will invite them to participate in a recorded video visit. During that visit, we'll collect cognitive testing and do functional status assessments to determine whether the patient has objective signs of cognitive impairment. And then we will also have the participant perform tasks such as walking and finger tapping and other movements on camera to get a good capture of their motor features. After this, we will have the EHR predictors as well as the video and audio data captured for the participants who we've classified as having normal cognition or cognitive impairment. And we'll use this for model development in AIM 2. So for AIM 2, we will then extract motor and speech signals. So we will use AlphaPose or 3D pose, which are deep neural networks designed to detect motor signals, to characterize gait and other movement patterns like gait speed, stride length, and other speed of movement. And we'll fine tune it on features indicative of motor disturbance or gait disturbance. We'll revise the model as needed using transfer learning from open data on movement, such as Gate 3D. For the speech data, we'll first explore large language models to extract conversational features seen with cognitive impairment. And if this doesn't perform well, we'll conduct supervised learning to expand to a visual language model using the audio data from the eRADAR positive and negative participant recordings. We'll also extract labeled data from our existing data sets, such as Dementia Bank, if our data set does not capture relevant speech features that are seen in cognitive impairment, such as repetitive speech or paraphasic errors. And then finally, we will combine the relevant speech and motor inputs with electronic health record data to develop and fine-tune new models and multimodal models to identify potential undetected cognitive impairment due to Alzheimer's and related dementias. We'll use cross-fold validation and evaluate the model's ability to detect cognitive impairment, as well as evaluate the characteristics justifying that prediction. And then in future studies, we will look to uh, determine how to deploy such a model in real-world primary care settings. All right, thank you for watching. Please feel free to contact me if you would like to learn more about the WATCH study.